the lovely introduction. As mentioned, today I'll be talking about my PhD project, which is looking at a novel therapy to reduce dementia risk in Parkinson's disease. I'm actually from the same lab that Julia's from, who just spoke, and it's pretty fortunate because she did all the hard work in trying to explain what MCI is in Parkinson's. So I'll try and keep all that stuff brief. But essentially, so you might be thinking, why are we worried about dementia in Parkinson's disease? Isn't it a movement disorder? And if you recognize either of these famous faces, Muhammad Ali on the left or Michael J. Fox on the right, you may already know that Parkinson's disease is primarily characterized by its motor symptoms. So, you might recognize the familiar tremor or the shaking or the slowness in movements or muscle rigidity. What you probably don't know is that the cognitive side of Parkinson's disease can be just as functionally impactful as the motor side. And so Julia already also mentioned this study, but I really like it because it shows just how, intrinsic to the disease all the cognitive stuff is. So the study found that from baseline to 20-year follow-up, 4 in 5 people living with Parkinson's disease had developed dementia. So essentially, if the patient lives long enough, dementia is almost inevitable. So the whole point of this field of research is to increase the functional independence of the patient, and in doing so, reduce the burden that the disease has on both the individual and society. So what treatments are currently available? Well, cholinesterase inhibitors are currently recommended for dementia in Parkinson's disease, but there's actually limited evidence to support their use in PDMCI. And so I won't go into detail explaining what that is, but essentially, yes, there's no real current treatment for MCI or preventative treatment for dementia in Parkinson's disease. And that's where kind of we come in and trying to think of novel therapies or drug targets that we can maybe use to target the disease at the earliest stages before that full-blown severe cognitive decline that we see in dementia. So to understand, how we could treat MCI, we kind of need to understand what it is. I really like this infographic as well. It's taken from Goldman et al. And it shows the different factors that all play into why we see such a vast cognitive heterogeneity in Parkinson's disease. So things like genetic factors and environmental factors, and even the way that we define and assess cognition all explains why we see such a vast array of cognitive symptoms, ranging from problems with executive function, so that's things like planning and mental manipulation, attention and working memory, problems with visuospatial ability, language deficits, and memory problems, or any combination of the above, essentially. What we do also see is that when people present with memory problems in this PDMCI stage, this is termed as Amnesic Mci. And the reason that it has its own little name is because people with AMCI are more susceptible to developing dementia more rapidly than those with other types of cognitive impairments. Now, the concept of PDA-MCI is quite new in Parkinson's disease, but it's actually a really well-established entity in the Alzheimer's field. And now our colleagues in the US have done a lot of work in this area looking at AMCI using this task. And now this is a pattern separation task, pattern separation is just a process of episodic memory. And what this task requires is for people to pretty much tell us whether each item that they're shown in a series of items is old or similar or new. Now, old means you've seen that exact object before. New means you haven't seen the object before. But similar means, you can see down here, it's the same object, but just a different version. And as you can see, it's pretty tricky to decipher between what is old and what is similar. Now, it's the correct identification of these similar items that's dependent on the DGCA3 region of the hippocampus. So this is the hippocampus, a rat hippocampus, and it is broken down into its parts. So this region here, the CA3 dentate gyrus subfield of the hippocampus, its activity is really kind of well taxed in trying to figure out whether it's a similar or an old object. So this is well established. What our colleagues in the US have done is they've given this task to people with AMCI, so that's pre-morbid Alzheimer's essentially, and they found that at baseline, the activation in the DGCA3 subregion was hyperactive in the AMCI group compared to controls. So that was pretty interesting. What's even more interesting is that when they administered levetiracetam to these patients, levetiracetam is traditionally an anti-epileptic drug, and they administered in really low doses to the AMCI patients. They found that they were able to not only normalize this hyperactivity and bring it back down to the control level, but also improve performance on that similar task, on the similar trial of the task. So you can see both amelioration in terms of activation in the DGCA3 subregion, but also the behavioral impairment on pattern separation. So we wanted to bring this kind of field of study to Parkinson's disease. Now, to kind of initiate that transition, we wanted to first confirm whether the hippocampus is even related to episodic memory in Parkinson's disease. So we did a systematic review of MRI studies, looking at both functional and structural MRI. We found that hippocampus structure, mostly the volume of the hippocampus, was pretty consistently linked to episodic memory ability in Parkinson's. Not only that, but the hippocampal subfields were also linked to episodic memory and cognitive decline in terms of their volume. But we did also note a pretty distinct lack of subfield studies using functional MRI. So no one's really looked at this CA3 dentate gyrus subregion in terms of its activity and how that relates to episodic memory impairment in Parkinson's. So that's where the TRIP study comes in. We wanted to kind of assess this using two different aims. Okay, so the first aim looks at validating the hippocampal subfield region in terms of its hyperactivation as both a drug target and a biomarker for people with Parkinson's disease at risk of rapid cognitive decline. Remembering that's that PD-MCI group. Secondly, we wanted to evaluate whether levetiracetam, that anti-epileptic drug, can improve memory in people with PD-MCI and normalize their hippocampal hyperactivity. So in order to do this, we needed three groups of patients. We needed not only people with PD-MCI, but also people living with Parkinson's disease without memory impairment, and those without Parkinson's disease and without memory impairment, so kind of like an age-matched, healthy control kind of group. And the reason that we needed these two groups in blue is in order to be able to assess whether this hippocampal subregion isn't actually a good biomarker, we needed to make sure it's specific to the PD-MCI group. In terms of our exclusion criteria, it's quite comprehensive. So the exclusion criteria here on the left is applicable to all three groups. And we're looking to exclude based on dementia because we're looking at MCI. Those unable to have an MRI, we excluded based on psychiatric conditions like bipolar, schizophrenia, major depression, current suicidal ideation, and any difficulty complying with protocol requirements and any other clinically significant disease. On the right here, we have another set of exclusion criteria, and this is solely for the people with AMCI who will be invited to participate in the trial looking at levetiracetam. So this set of exclusion criteria is essentially just looking at whether they are able to safely take the drug. In terms of the screening process, it's quite involved. So we have not only a telephone screen and an online questionnaire, but 2 clinical interviews that are done in person. And then by the end of the clinical interviews, where we do the comprehensive cognitive assessment, we'll be able to, identify whether someone has PD-MCI or not. And so those that do show memory impairment are invited to continue the screening process with more of a medical assessment, and then invited to enroll in the trial. And those who don't show memory impairment are just invited to undertake the MRI pattern separation task that I mentioned earlier, again, as a control. So how do we identify AMCI? Well, we do use the level 2 MDS criteria for PD-MCI that Julie mentioned in her talk. We look at a failed test of a score 1.5 standard deviations below the norm. And MCI is considered 2 or more failed tests, with a MCI being at least 1 failed memory test, remembering that there's 2 tests within each of the 5 domains. Most important thing, I guess, is to make sure that functional ability is retained, and we measure that using instrumental activities of daily living. And that's important because that's the main difference between full-blown dementia and just the MCI stage. Other clinical measures that we collect: global cognitive assessment based on the MoCA, Mini Plus to gauge neuropsychiatric symptoms, UPDRS, which is a very common scale in Parkinson's disease research, looking at Parkinsonism and the motor and non-motor symptoms. We have anxiety, depression, apathy scales, the IADL, and the clinical dementia rating scale as well. So how do we address our aims? As I mentioned, we have those 2 control groups that do the fMRI task, and we will compare their performance both in terms of the activity in the DGCA3 subregion and also their behavioral performance on the pattern separation task with those with memory impairment. Remember, that's that PD-AMCI, high risk group. And we expect to see that hippocampal subfield hyperactivity and impaired pattern separation in the PD-AMCI group, the people with Parkinson's with memory impairment, compared to the other 2 groups. In terms of the clinical trial, it's a lot more involved. So we'll invite people living with PD-AMCI to pretty much take a study drug for 2 weeks. Now that might either be the active drug or the placebo, have a 4-week break, and then switch. So that's what the crossover is. Those who are taking the active drug will then take placebo and vice versa down here. And that's just to control for any order effects that might exist. And of course, this is all blinded as well. And then at the end of each treatment phase, they'll participate in the fMRI task, so the pattern separation task at both points. Now we expect normalization of the hippocampal subfield hyperactivity and improved pattern separation in those with amnesic memory impairment on active versus placebo. So that's the purple versus the blue highlighted groups. So recruitment at a glance, we're still recruiting for this study. Will be into the next year as well. But so far, considering we've started recruitment of non-Parkinson's controls in January, we've managed to successfully scan 19 participants. Those recruitment of Parkinson's disease patients started in September, and we've successfully scanned 5 people living with Parkinson's. So we're on our way to our goal of having 28 in each of the 3 groups. So hopefully you can all see the significance of this body of work. We are looking for a novel biomarker for dementia risk in Parkinson's, which would be very useful in guiding our treatments or research and treatments in the future. We're also looking for a repurposed treatment for MCI in Parkinson's, which would be ideal, so we don't have to go through all the red tape that it takes to get a new drug out in the market. And finally, and above all, really, I think this body of work just wants to further the understanding of the cognitive subtypes that exist in Parkinson's disease and to understand their neurobiological underpinnings. That's all from me, and I welcome any questions.
Thank you, Dana. I have a question. You had many clinical measures listed, and most of them are quantitative. Well, some are categorical, obviously, but they are interconnected. How do you track their correlation, if you like, in quantitative terms in your study?
That's a pretty good question. I don't think that I've thought that far ahead because in terms of analyses, I don't think any of the clinical measures will actually be within any of our, outcome measures. So our outcome measures are looking at activation in the hippocampus and also the behavior on the pattern separation task. So in terms of actually looking at the correlations between the other clinical measures, mostly they're just used to be able to define the sample and look at whether, we do need to control for those kinds of differences amongst the groups. But I guess, in terms of being able to control if there are differences, there are different methods that we can use, particularly when it comes to, I'm still learning all the imaging stuff, but in terms of the behavioral analyses, I guess, just being able to control for them, and those might be sufficient.
Yes, actually, you mentioned the relationship with Julia's study, and she had a nice presentation, graph where she had some outliers in it in 3 arms, I think she was looking at. So maybe some of these clinical measures will be key to explain why they are outliers, or I'm not sure how this is related exactly to your setting.
No, but you're right. It is a pretty similar, we're looking at people with Parkinson's disease in, functional MRI scans. Maybe we will be able to find some sort of link between certain clinical measures and why, someone tends to be an outlier or not.
Thanks. I have one more question from Linda. Well, can participants come from outside of Queensland, or do they need to be in person attending the trial?
Unfortunately for this study, you do need to be in Queensland. We're pretty lenient with, whoever wants to make it out to the RBWH can come, but because it is an in-person study, for now, I think with COVID, we are looking at how to make things more remote and, perhaps delivery of the drug and finding different sites or whatever. But considering, I also don't think I mentioned, this is only a proof of concept study. So if this is successful and we do see a signal, there's hopes of expansion. So that would be good.
Well, your talk will be published, and Linda can get in touch through us with you. And if you keep Linda track of development on Dana's project, then you'll be informed. Thank you very much, Dana. It was very interesting talk, and wish you all the best in your research.